A grandmother in Botswana can read someone's health from the way they sit down in a chair. A healer in the Mara can know what's wrong from a person's story, not a blood test. Is that evidence? Well, global health has said mostly no. This episode of Redefining Global Health in the 21st Century, this episode asks, what if that's a big mistake? What if we're missing something by ignoring those lessons? Who gets to define knowledge, and who pays the price when they get it wrong? Well, hello, welcome to Redefining Global Health in the 21st Century, a new book written by Reid and Eric Goosby. Mike and Eric are here with us today. Gentlemen, good afternoon.
Good afternoon. Thank you for having us.
I'm Ben Plumley, and I'm going to help try and navigate the conversation. Mike, you, if I may start with you first, you've listed a number of things in the chapter on epistemology, but there are some things that you haven't included. There are things that you're toying with at the moment, new ideas. Before we get into it, do you want to just share with us what those are and how perhaps we can feed that into the conversation today?
Thanks, Ben. Maybe I'll just back up and say, for those who are not familiar with academic jargon, that the term epistemology is really the study of knowing, how we know what we know. And in the context of global health, one thing we don't talk about in the book is how global health is understood to those outside of the global health community, and specifically to taxpayers, the regular citizens in the US. And I think a major failure within global health is making the case for global health as an investment priority to the US citizenry or to taxpayers in high-income countries more generally. So that's not covered in the book. I'd love to talk about that with you today. But I think what we try and talk about in the book is who gets to decide what is important in global health, and how. And so we talk a little bit about how the historic precedent over the last 20 years is that actually the priorities that inform global health investments are biomedical priorities, they're epidemiological priorities, and they're informed by a set of metrics that are sort of defined within Western ways of knowing. Targets we use, the kind of ways of evaluating things. And maybe there is an opportunity moving forward to both think about what are priorities to our partner governments, both in terms of their epidemiological priorities, but also in terms of how we measure impact, what's important. Because I think there is a tendency, and has been a tendency, for global health to spend far too much time focused on the priorities that are defined by policymakers, politicians, researchers in high-income countries, rather than ensuring that those priorities reflect the true priorities of folks in low and middle-income countries. And then I'll say one more thing, and then I'll push the conversation back to you. I think the final thing we want to talk about and bring to the fore in global health is not only what are the priorities, but what is our posture in defining those priorities. And actually, I'll just pause here and just honor Eric's legacy. I think Eric has been, for many years, and anybody who's worked with him knows this, has been one of the most humble leaders in global health that we've ever seen. And maybe just a fun, interactive exercise, we can ask our viewers or listeners, just if you have an experience of working with Eric that reflects that, double tap or add to the comments, because we'd love to hear them. Yeah. But I think the academic term is epistemic humility. The idea that we don't have all the answers, that has to be a key priority for the global health community moving forward. We need to move away from sort of the hubris of thinking we know how to do things, we've solved all the problems, to recognizing that actually for the future of global health community and the things we invest in, we need to bring humility to that whole everything that we do.
I find that fascinating. because if I think of global health, the last thing I think of is humility. In the course of my career, a little bit longer than yours, over the 20, 30 odd years of working in this, we've actually become much more arrogant and possessive of the way we define data, the way we define metrics. And Eric, I think it's a sort of a good point to bring you in here. I completely agree with Mike. I don't know anyone in the global health field who is as humble as you are. And I wonder at times whether you've done that deliberately. It isn't just by accident. It's not just because who you are. Mm-hmm. It's a way of getting solutions that might be missed. And do you feel that we have lost our way in an open and humble approach to learning about global health?
Well, thanks for the kind words for both of you. But I do think that humility does allow for a different conversation when you come in holding a lot of the resources and coming into a country that holds all the content of the problem. What you potentially can miss by not having the right person at the table to discuss what the problem is and for whom is you misunderstanding the I think critical pieces of how that virus enters that population, moves through that population, who are the groups that are more likely to get infected, become conduits through which the virus penetrates the population more thoroughly. Understanding those conduits becomes a part of your prevention strategy and becomes the map of how you set out where you identify, enter, and retain those patients for the duration of their infection, their life, in a continuum of care and services. When you don't include that portion of the community that's impacted in that conversation of what do we need, what is the problem, who and where is it affecting our community, you miss the ability to respond to it effectively and take years figuring out where to put your testing, where to put your loss to follow up, what portions of the community are trusted, not trusted, dealing with a disease that has high levels of stigma, both HIV and TB combined with this disease run together. And if you are not understanding that and addressing that on day one, you're going to address it on day 10, 20, 30, and 300 for sure. So I think the ability to make a program that's impactful and resilient is enhanced by including those in the very beginning. And a arrogant, I know everything resource as the funder, it can destroy everything in one conversation. Seen it a million times. So you're either justifying or recovering ground won or lost thereafter. And so I think it's critically important.
And I'll just add to that. I think if you look at the trajectory of PEPFAR over the last 15 years, you see evidence of how humility has informed, or lack of humility has informed programming. I think during Eric's tenure, there was a deep commitment to partnership, and the partnerships framework was one example of that. Unfortunately, moving forward, I think there was far more of a kind of a command and control approach where we are going to demand these results, and funding will be contingent on these results. And that led to tremendous progress, but it also led to some distortion of data and some bias in outcomes that I think reflected that people were being responsive to the expectations rather than being included as true partners. And to use that very cliched African proverb, if you want to go fast, go alone. If you want to go together, go slow, or go, whatever the term.
You want to get faster alone, together slower.
That's right. And I think that.
But you get there.
Yeah. I think perhaps part of why we haven't ended up achieving all that could have been achieved or ensuring the sustainability of the PEPFAR investment is when we retreated from that posture of humility into a more command and control approach to donor financing.
Which is where we are now. Again, the results that we are expecting to measure success are driven from Washington. They're not driven by the countries themselves. There's a quote from the book, which, if I may, measurement is rarely neutral. It embeds assumptions about what counts, and who does the counting. What has global health been counting, and what has it been missing? And that ties us back to the introduction that we're very good at measuring these complex academic, MPH, even Masters of Business Administration approaches to success. We have no space for the Botswanan grandmother. And I see that as a major failing and a reason for why we are where we are. But does that make sense to you? Or is there another way of thinking about how to include measurements from local communities that might not have the same kind of metrics behind them?
Yeah, I don't think we dispute the value of those kind of more scientific measurements. Look, a lot of the progress that we've seen in global health over the last 20 years is because of biomedical empiricism. We've learned from rigorous biomedical research, from RCTs and other forms of analysis. And in the global public health space, that has driven forward progress based off of metrics that are derived from biomedical definitions of progress. That is all good and has saved a lot of lives along the way, for sure. I think the point we're trying to make is that there has to be room to capture the insights and the progress across other dimensions. For example, the sustainability of the programming, but also engagement of community partners and closure of equity gaps that may not be captured in the targets that were being required by US Congress, for example. So I think the call out is to be thinking more holistically about how we assess the value, the efficacy, the sustainability of programming of global health activities writ large, if global health is to sort of survive this inflection moment.
I was just going to say that to me, the lack of an appreciation and nurturing of the motivation that gets the donor and the partner country to come to the table to develop a continuum of specific care and specific services for a specific population, that's got to be what we focus on. Must be included in what we focus on. We have to have a reason to come to that table to plan and implement. Without it, it wanes with time. And it especially wanes in the partner country's commitment to continue to support it. And but is the reason why those local reasons to engage, the motivators, the outcomes that they're interested in, need to be included and mixed into the outcomes that we know move the diagnosis, treatment, and cure of a disease forward. Because that's what the game's about, especially for the donors. That's really what they're looking at to continue the investment. But it needs to completely integrate with why the country puts their resources toward this as well, both in resource money, but also in investment in human resources and commitment to the idea that their population gets health care. That must be revisited as the core reason we engage. Without it, we wane. And I think we've made that mistake over and over again.
Yeah, I agree. I would add that the problem starts upstream from that as well, though, insofar as who gets to define what the problems are and what are the problems for the problem, the solutions to the problem, rather. Yep. And I think that there, I think the academic global health community has some responsibility to rethink how we do our science around global health.
Ben, you use a wonderful example in this chapter around maternal health, and measuring success is getting women into facilities so that they can be maximally looked after. And yet, so many women want to deliver at home. And there is a real crashing tension between, well, why are these women not doing what we know they ought to do? And what is it about their reality that makes home delivery so important? So in many ways, and you pose this question, I think it's absolutely right. What exactly is the impact of naming an unmet need, like delivering at home? It's not an indicator of failure. It's perhaps just a lack of imagination in thinking about how to bring together the plurality of ways of measuring, of ways of delivering services.
It's the kind of thing, Ben, where if understanding that there are many goals that are part of the same act in implementing a program, you're there for a variety of different reasons that get you to do it, but that they both need both of them to stand up a program and have that program be resilient in the context of the society that we're building it. They need to believe that it's there for their reasons too, and we need to show that there's a dotted line connection to it. Without that, I guess I'm saying you need both. You can't really just do one or the other. And the appreciation of needing both requires a local knowledge that often exceeds the donor's ability to glean the kind of motivators that are acting out in front of them as they try to implement this program. But I think that I don't want to, and Mike already said that, those outcomes are the outcomes that we're after because we know the population drops the disease and its impact on them with these things being achieved. And we've seen that over and over again. If we can't convince you of that as a partner country, there's a problem.
Yeah.
And then we got to address that.
The other example I think in the book is the example of differentiated service delivery models in HIV programs. Probably about 10 or 15 years ago, there was a recognition that actually if services could be delivered outside of clinics in the community with community supports that could offload clinics and allow more services to be delivered to more people, makes a lot of sense. And suddenly with that recognition, there was a huge influx of resources. We saw a massive increase in the number of people who are accessing HIV service delivery in many LMICs. What is notable, though, is that many community actors had been saying 10 years earlier, hey, look, if we did this all in the community, we could scale much more quickly. And the donors didn't fund that. They didn't fund it until they became aware of the insights themselves.
They discovered it.
That's right.
And we did the same thing in the United States with counseling and testing in a freestanding testing site was how we started this whole thing. And for 12 years, that's all we did, which was hard to believe.
Yeah.
But we did.
Yeah. And I guess the lesson there is like listening to the communities most affected early on and including in the co-design process is not only morally the right thing to do, but probably the most cost-effective, cost-efficient way of doing things. And yet oftentimes we don't do that, particularly because it comes with a risk, right? It becomes with a risk that things won't happen on the timeline or in alignment with the priorities that high-income country donor programs have prioritized.
But that's our problem.
It is.
That's not the problem of the countries or communities, right?
Having so many owners, kind of landlords and people renters and land grant owners of the buildings deciding what the rent is has put a disconnect in it that we need to acknowledge is counterproductive, but it also precludes our ability to build the resilient programs that we need. And if we're really serious about that outcome, dropping whatever that we're trying to do, number of diseases, number of people with the disease on treatment, and getting better, and et cetera, as the goal, those are hard outcomes that need to be included in what you measure. But we also need to understand how issues of access and kind of maldistribution of who gets access and are retained in services over a disease that requires a lifetime of an interaction is also just as important. Because to get them for 3 months or get them for 2 years, but not get them for the 10 or 20 years is a loss. Is a failure. And I think the system needs to understand that.
This speaks to one of the arguments you put in the book, integration versus verticalism. And I'm sort of interested to understand more because from a policymaker's perspective, your audience, your masters are the parliaments, the congresses who are wanting this money to be used but show that it's effective. But they want it to have a very simple record of effectiveness so that they can just move on and continue or move on to something else. How do you break those silos? Where does the integration come?
Yeah, I mean, I think this speaks to this challenge of whose knowledge is prioritized, right?
Yeah.
Because the U.S. taxpayer and the politician who represents them wants to be able to see that their investment leads to outcome X or Y, which unfortunately leads to very vertical siloed programs. At the beginning of the HIV epidemic, that was by necessity the only and the best way to deliver programs in countries where their primary care infrastructure was so fragile. But over the course of time, I think the impetus or the necessity for verticalized silo programs diminished for partner governments. And I think there was a repeated call to try and integrate HIV programming into primary care, which wasn't honored or wasn't prioritized by USG or other donors for precisely this reason. How do you resolve that tension? Well, I think one is sort of epistemologically to sort of reinforce what I said before, which is actually being responsive to the needs of the government, integrating HIV into primary care as and when they're able to, is more likely to lead to sustainability and long-term cost effectiveness, as well as long-term epidemiological impact. I think the other lens, though, is that by integrating, it's quite possible that there are, in real time, some positive externalities that are less easy to define or measure, but are equally important. So strengthening HIV service delivery within a primary care infrastructure, by its very nature, may well also help optimize diabetes outcomes, reduce maternal mortality, those kind of metrics, which I think are underappreciated or have been underappreciated over the last 20 years. That's not to say that people haven't measured them. And look, there's a fair amount of super compelling evidence that actually HIV has had PEPFAR has had really profound impacts on under 5 mortality and maternal mortality, even the likelihood of adolescent girls and young women graduating through high school, all of those sort of positive externalities from investing in HIV programming. But I think if we'd have done a better job of measuring those, there may have been greater willingness to
Like
invest
finding other disease other than HIV, which we've only looked at a little bit, will be huge. How much hypertension, diabetes, and coronary artery disease did we pick up because we saw that HIV patient 3 times a year, every other month, every third month? It's huge. And we don't even measure that, those types of benefits.
But there's a problem here. And that works where the government and the community welcomes these populations into primary care and the cascade of care that comes with it. With HIV, even in hard-hit countries, we still see populations most at risk of HIV, most isolated and marginalized, like people who inject drugs, men who have sex with men. And to what extent can this comprehensive, integrated service account for their needs and account for bringing these populations into services?
Look, I think one of the important principles that should be elevated in public health programming more generally is equity. And in order to prioritize equity, sometimes services for underserved populations or populations on the margins have to be delivered separately, because to try and integrate those services into routine primary care infrastructure can undermine care for those programs.
Doesn't work.
Yeah.
Yeah.
So I think you have to do both, right? And I think that, I think that's an essential function of public health programming, different from health systems for other programs, is that priority around equity. I think having an inclusive epistemological agenda for your health programs that allows you to capture that. And I would say this, I would say that if you look at PEPFAR's legacy, specifically over the last 20 years, one of the things that has been really remarkable is its ability to close those equity gaps, at least up until 2025.
Yes.
So there's a really lovely paper that is published by UNAIDS, led by Nanda Kumar, a health economist from Boston University, where they basically looked at, like, I think 9 different countries, and almost without exception, equity gaps closed over a large period of time, at odds with broader sort of secular trends in those communities. And I think it speaks to the fact that PEPFAR has been historically really focused around equity. The big concern is moving forward, will the current administration prioritize equity? And, I think we can speak to that if you would like. I think there's grave concern that in a PEPFAR program that doesn't elevate the importance of key populations, MSM, sex workers, transgender people, those equity gaps are only going to widen. And I think the current administration will be found out on that. I would even go so far as to say that you can't run a credible global public health program unless you care about equity. And so begs the question whether PEPFAR is even more a public health program. But that's an aside.
But I mean, knowing that you are in an unethical position to move forward without taking it into account.
Thank you.
And that is without doubt a strong belief on everyone who's worked on this side of the equation. To abandon that is a terrible mistake and has no ethical basis. It's also not based in the science that we know or we claim to know. But I can say that the inability for countries, their side of the epistemology equation, is that they haven't defined if they're doing a primary care, universal health care is available to their population or not decision as a society. And without that decision, you're just band-aiding the problem. You're not engaging and implementing a response that's accountable to itself over year 1 and year 300. You are not committed to responding to the disparity that is in front of you before you have any response to a disease. It's just going to get bigger. So I think the ethics of this speak loudly to backing up a bit in the decision to allocate resources and prioritize this unmet need of many in a country as the one you're going to fund. The country needs to create a process that opens it to public discourse to decide, do you as a population in my country want healthcare as part of what we try to do for you? We can't guarantee it yet, but we're going to work to guarantee it and say as a country, this is our number 1 priority. And with the population behind it, That momentum will not stop. It is what we should be doing with governments. The governing that should occur should be to take care of the service needs of their population, first, second, and third, and then the other stuff comes in later. If governments just started doing that, we would transform the world.
But they're not.
They're not, no.
And here's, and this is why this is such an important dilemma for the work that you are doing. We're encouraging, ultimately, country leadership, and they set the agenda. If you have an agenda that excludes certain populations, and in fact, in many cases, and you'll know this from your advocacy in Uganda, that there is an argument to say, well, frankly, these people shouldn't be having healthcare because the sooner they're extricated out of our health system, we will be able to meet the holistic goals. We're not having to deal with populations that we either think shouldn't exist or should change their behavior to a more established.
Ben, the science tells us that approach increases transmission into your general population every time we've looked at it. Did it in the United States and every community you looked at it in.
Yeah.
So 57 different times it did the same thing. You need to target the high-risk populations and create a different point of access and retention strategy at the beginning of your response and integrate at the same time. Put it in primary care health sites. Don't put it in infectious disease hyper-specialized clinics. It needs to be available where the population is, and they're funneled. The patient with the positive disease is funneled to more and to a more knowledgeable provider. You funnel the patient.
So you have an arrangement with the new PEPFAR model, which is to treat pregnant mums and young babies. The policymakers in the United States are explicitly excluding hardest to reach, most marginalized populations from an ideological perspective, not a scientific perspective. And one of the arguments that has come in favor of this approach is that there are elements in the leadership of many African countries, particularly, that share those views. And so we really have a dilemma of decision makers supposedly being led by Western data, choosing to ignore it, and countries that feel that they are able to re-emphasize their hostility to these populations. I don't know that there is an immediate solution beyond going back to the data and showing and convincing people what can be done.
Maybe I can just reflect on that. I don't know that I have a solution. First is just a clarification. My understanding is that the current administration have decided that they will not fund programming to these priority populations, or what we used to call key populations. But they are not opposed to partner governments investing in prevention programming for those populations. So if the government of Uganda decides, yes, we want to invest US government resources in providing prevention programming to gay men, then the US government is not going to stand in their way. But in the current political climate in Uganda as well as in the US, it remains to be seen whether they will prioritize accordingly. But that's an important but semantic point that's worth highlighting. In terms of a solution, I think it's worth being political rather than partisan on this issue, and just highlighting, as Eric did, not only the scientific epidemiological value of these interventions, but also like the moral imperative, regardless of where you stand on the kind of ideological or theological spectrum. Like, withholding care from people is ideological. objectionable to all societies in my mind. And I think that one of the solutions is to empower community voices, both in high-income countries and in partner countries.
What we didn't do.
That's right. To raise a loud and noisy voice in defense of those who are underserved. And I think the imperative is to empower like some of the communities that are not most impacted, like the church, faith-based organizations, to advocate for this. And certainly in Zambia, Circle of Hope is one group, that faith-based organization that are doing tremendous amount to support care for MSM, and maybe a model for how this can be done elsewhere. So as part of an answer to your question. Yeah.
Just one final point on this before we move on. I mean, it's not just a global health issue. It is a domestic health issue, as you see the way in which services for trans populations are being cut. And the organization that I'm involved in, the San Francisco Community Health Center, that provides 80% of services to the trans population in San Francisco, is right on the front line, is suing the government, suing the administration for some of the policies that have been put forward. But it's real here as well. So it's back to your point of learning from each other.
And I think, one thing that we have done with great detriment is we've created, and this is a society at large, we've sort of created a them and us dichotomy between, whatever the issue is. On this case, it's sort of, trans health issues. And I actually think if you brought together faith-based organizations and trans community organizations in San Francisco, and they were able to better know each other and collaborate, you might find that there were some powerful allies that could support and advocate in addition, rather than what unfortunately happens across a whole range of different ideological issues, is we create otherness.
Yeah.
And I think that's one of the things we're trying to say here, is like, we need to move to a point where we're able to hold differences of opinion, but also recognize that we have a lot of shared knowledge that, and values.
There are differences that we need to fill, that we can embrace and not be frightened by, and not feel we need to change, and not allow that other category to be self-defined. If it's the motivation should be to respond to an unmet need that is worthy of being responded to. And this issue, to make it you're taking something away from us as heterosexual society, trans people are taking something from us, is an absurd interpretation of what's occurring. And they've gone way out of their way to put in the language and the perspective that diminishes and separates, as opposed to looking at a commonality of human need that we can both groups respond to. It is such bullshit to choose to go down the dark pathway, and we are better than that and smarter than that, and as a society, I believe, can come above that. But it needs to go back to a choice. It can't be this shove down your throat approach to a legislative appropriation decision. We need to decide as a global community. That conversation needs to find somewhere to happen, that there are certain human needs that the global community needs to work to deliver to the people that need them. And we all have a role in that. And it doesn't stop with a country saying that we are the lion's share of the resources going to this, and we now are going to unilaterally decide that this is something we're going to fund and this isn't, without a public discourse. To unilaterally, quietly, privately hit with a hidden, process, decide it with no attempt to discuss it with those who are going to suffer from the outcome of that decision, is morally corrupt and wrong. We're better than that. We're better than that. And people just don't believe that anymore.
So that leads us very nicely into, or whether it's nicely or not, I don't know, but it leads us to the conversation about epistemology and power and how the two relate to each other. You cover this fairly extensively in the chapter, and there's a lovely sentence that I picked up, which I think helps frame the conversation. You say, is aid fundamentally an epistemic act? And if so, what does that mean for how we give and receive it? And you're throwing by that, I think, the responsibility to those who own the power at the moment, which is the donors.
Yeah. I mean, it's quite simply, I think that's look, we represent a high-income country here, so I think that's where our onus of responsibility is to speak truth to that power. Eric did allude to this earlier. I think there is a separate parallel agenda that needs to inform how partner governments prioritize their public health programming as well, so that it closes equity gaps, so that all populations are served. But I think for the investments from high-income countries like the US, we do need to continue and iteratively rethink what are our public health priorities in a way that is inclusive of the agenda of the partner governments and the constituents who are going to be receiving those funds.
Yeah, really getting rigorous around lines of accountability is something that we didn't really close the loop on with PEPFAR and needed to. It was clear then, we just didn't get to work on it. But the optimal situation is the people in the country in which we're doing the work hold their political leadership accountable to make the allocation decision for them. That is where we need to get this. So it's a self-contained, feedback loop that keeps that country and its resources focused on their problem. And when there's an external resource that's hovering out here, that it has a way to articulate that potentiates, that's additive and not, some kind of positive and negative, subtraction, addition equation, but is positively delivered. That we are smart enough to do, but for reasons that are not clear, had never really done it as a global community. And are we at the precipice of this with the, I think, rawness of what the Trump administration has shown us in their willingness to make decisions that are so exclusionary, they're willing to let people drop off the resource response list to the point where they are allowed to die unresponded to. That hasn't been an ethical part of how we've put our world together until now. Now it's presented as an international option to believe and think that way is sanitized. It suddenly isn't an insane thought. It now is something that we're considering. And this administration has brought that to the table, and we now cannot not respond to that.
So how then do we alter the dynamic between epistemology and power? And you look at that wonderful phrase, global health infrastructure architecture, which is mind-blowing, actually. It's just crazy. It's all about the institutions in Geneva and New York and across the UN. But how do we use this new inclusive epistemology to strengthen?
So I think part of it is rethinking who gets to set priorities for donor funding and for health programming writ large, right? And a corollary of that is who are those individuals who set the priority and who do they represent? And I think if it's white, straight men, like the kind that I embody, then you're likely to get a particular set of priorities.
Yeah.
If we really are serious about a more inclusive, transformative approach to global health, then ensuring that the leadership of both the sort of global institutions, as well as the sort of implementing programs, needs to reflect the diversity of different perspectives out there. Unfortunately, when you look at many of those global governance institutions, they do historically overrepresent white straight men. That's not always the case, but I think it reflects a way of doing business that I think has undermined global health initiatives having the potential impact that they could have done. And I actually think one of the most enlightened appointments in U.S. global health programming over the last decade was the appointment of Ambassador Kengason. He was an African American who knew the HIV response in Africa better than everybody else. Was connected to political leaders across the continent and held the promise of being able to realize an end to the epidemic. Unfortunately, Ambassador Kengason was held back by political forces in DC that I think, were a great frustration and reflected sort of domestic political realities and lack of global health ambition that preceded Trump. So I don't want to put all of the blame on Trump, because I think we appointed Kengason. He could have delivered if there was political will for him to do so. Yeah.
I think it's important to recognize the failings under the Biden administration that did not give John the kind of security that he needed. One of the areas where I think we started to make some success, and you refer to this in the book, is over COVID. To begin with, classic northern instructions to southern countries: get in line and you'll get your medications after the north has done so. And it forged I think a really interesting mobilization from African countries particularly, who had got the experience from HIV of having to deal with donor priorities, but working around them to do the things that they wanted to do. It begs the question whether we need crises to push us to do the right thing eventually. Do you think the situation that we're in now, not just with the United States, but with European countries, the UK, France, less so Germany, in reducing donor funding, is that an opportunity for us, do you think, to build a better relationship between North and South?
Definitely. I mean, I think the US stepping back from global public health leadership creates a vacuum and an opportunity for other partners to lead. And my hope is that we'll see that. We'll see, innovation and solidarity from political leaders across low and middle income countries, that where there perhaps was diffidence or deference to high income countries like the US in the past. So ironically, we may be entering a period of more sort of diverse, inclusive global health leadership because of the absence of US leadership, which is no bad thing. I think that's certainly true in the WHO space, where I think the US exit it creates a massive fiscal vacuum, which I think will be hard to fill. But it also creates an imperative that other countries step up and lead. And there are new models of governance and leadership that are multipolar, that are more equitable, diverse. That, I think, could be a really good thing. And, as much as we try and paint a positive or an optimistic vision for the future, part of that is looking to this as an opportunity to reimagine something different that isn't based off of US hegemony, but is truly inclusive in a new way.
I would say that the biggest potential excitement in the Trump administration's approach has been this potential that the vacuum created matures new players that would not have matured on their own, and creates a necessity of action that isn't there without the big player playing. And I much would have preferred the big player continuing in the United States and us using a receding kind of posture, not a absence posture as the impetus, and allow new partnerships to flourish out of that kind of a context. To do it out of a vacuum is really a mistake, especially when you're dealing not with making a new tire or making a new diesel part, but when you're dealing with all the lives that these programs are touching every day and have for so many years, to just take that away is unconscionable and will be, I'm afraid, the legacy that is remembered.
Yeah. But I would say that, Eric, hopefully there's a point in the not too distant future where the US will resume an important leadership role in the global health ecosystem. And when it does, hopefully it is a more vibrant, diverse ecosystem that
we come back smarter.
Yeah. And more humble.
Yeah. And more humble.
And our country partners or country leaders are much more adept at getting what they want from the funders. You have a whole chapter on the climate, so I don't want to get into that in any detail here. But as I read this chapter, you seem to be arguing that the climate crisis that we have is actually going to force some of these changes upon us anyway, because the climate crisis is not, like HIV, determined by country borders. And I think for this conversation, it's sort of more about how we maximize our relationships with climate policymakers and advocates to create an integrated epistemology.
Yeah, I think that's probably true. I don't know that we phrased it quite like that, but I certainly agree. I mean, it is my deep conviction that the defining global health crisis of the next 80 years is going to be all about the deleterious impacts of climate on health, a range of health issues. But we need to have a coherent global response. That's what that chapter is focused on, that addresses the threats that climate poses to health systems in vulnerable places, as well as the broader threats that all communities in both high and rich countries will have to face. And having an inclusive epistemology that sort of helps codify what are the right research questions and what are the right donor investment priorities will pay dividends in responding to that climate threat.
You know, one of the things that really upsets me is so much of the knowledge that we've already accumulated, identified, and prioritized as helpful to human beings doesn't reach the place where it will achieve that. And we don't grieve about that. We hardly monitor it. Indeed, most people aren't even aware of it. But what is going to happen as you get better and better at treating things, which, the extraordinary ripple that the protein GLP-1s have done has been extraordinary to me. I've never seen anything quite ripple that way so quickly, so ubiquitously throughout society that I'm humbled by, boom, how this just happened. Something like that is going to, now there's those inequities are going to be more urgent for people to say, I'm not getting access to those drugs. Chemotherapy wasn't enough for people to say, why can't I get it? But should have, but didn't. But, longevity stuff is just on the horizon. That's going to push a different thing in developed countries than we've seen.
Yeah.
Prediction.
Yeah. Well, funnily enough, I think I have a Substack post exactly on that.
I look forward to it. Thing that interests me, looking at African advocacy, is a generation of young Africans.
Yeah, me too.
Who would describe themselves as climate activists first, and who are putting enormous pressure on their governments. I think of some of the Kenyan activists and the Tanzanian activists, and I'm fascinated by them. And I know we are building up a new generation of AIDS activists and advocates. And I think the thing that would be, I don't know who does this, but forging the links and a cohesive, integrated advocacy would seem to me to be one
timely, really needed, really timely, and will take a very knowledgeable person with an eclectic background, such as yourself, truly, Ben, who's had this unusual trajectory of experiences that inform you to play that next role. That's the kind of step we need at this point. And I think it's going to include, societal-wise, a lot of issues are going to converge. It's not just the global health issue, but it's one of them.
Can I go back to something Eric said just a minute ago? So Eric, you made the comment about how a lot of knowledge is generated and doesn't ever reach the communities that where it has most benefit. And we sort of allude to this, but the book just touches on very briefly this issue of decolonizing global health. But I think academic global health over the last 20, 30 years has a lot to be fairly ashamed about. We have done a really lousy job of not only disseminating the science that's been generated, but also engaging local partners in that. And, we have to look no further than UCSF. We did a recent analysis where we looked at over the last 10 years, the number of first author publications on global health papers that UCSF faculty had written and the proportion that were from those low-income countries. And there's no shift. We're not seeing a more enlightened shift towards greater representation by our partners. If anything, it seems like over the course of the last decade, there has been stagnation in that sense, which unfortunately sort of represents some of the ways that academia works more generally. The incentive for academics to be first author on a paper is so much greater than than the incentive to facilitate another partner to be that first author. That maybe that's changing, but I think when you have that at the very
Mike, even if it changes, it's not the solution. Well, if you know what I mean.
I get it.
Yeah.
I guess I'm just saying that it just even at this one end of this sort of continuum.
I hear you.
There are forces that make it really hard for us to take a more inclusive epistemological approach. I think universities could do a lot to change that by changing our incentives around what does academic promotion look like.
Yeah.
Those kinds of things, and we could do a much better job of enabling that, and we failed.
Yes.
And academic global health is only part of the problem, but we can't absolve ourselves as academics from that. Yeah,
which is, I suppose, one of your penultimate sections in this chapter: the move from epistemic authority to epistemic justice. And there was a phrase that really stood out to me, and that was this binding principle you look to, that there has to be a preferential option for the poor, regardless of whether knowledge comes from RCTs or lived experience. You say its purpose must be to serve the most marginalized, and that this is a strategic objective for a future epistemology.
Yeah. So that has both theological and academic roots that I'd love to just kind of honor. That preferential option for the poor, as Ben, as a theologian, has deep roots in sort of Catholic traditions and the liberation theology of folks like Segundo Galileo. And we want to highlight and give prominence to that kind of notion. But in the global health space, I think we've had some really visionary leaders who have embodied that at scale. Paul Farmer is a great example where his professional career was deeply devoted to ensuring a preferential option for the poor, and the legacy has been written about and is worthy of honor. But it also makes good science sense, and that's the point Eric was making earlier. And we have this case study from Uganda, the imperative for prioritizing the poor, however you define poor, is both an economic and an epidemiological one. In the HIV space, we know that those communities on the margins are the ones that are least likely to have access to treatment, least likely to be on treatment. And if you can wrap them up in affirming services, you can control the epidemic and save governments money. So it's not just a moral imperative, it makes political, economic sense as well.
You just got to convince the people with the purse strings, country-wise and donor-wise. We're sort of coming to the end of the discussion on this chapter, on epistemology. What have we missed? What are the things in the book that you'd like to see?
So one thing that I think I'd love to have Eric's perspective on, and it's really sort of the internal reflection on epistemology, insofar as how do we share our knowledge better domestically? And I think an accurate critique of the global health ecosystem from the Trump administration when they returned to power was, if these programs don't make sense for the guy who works in McDonald's in Michigan, is this worth our investment? And I think global health community writ large have done a lousy job of telling the stories, of elevating the importance of global health to the US citizenry. And it'd be great to hear from you, Eric, like, how do we redress that moving forward? Because I think to show our value, the value of global health, we have to be able to demonstrate its utility to, the guy who works in the fast food restaurant in.
To me, we've missed that boat. We have not justified the taxpayer dollar being in a large way going to efforts that take care of the health thousands of miles away for another group of people. Even though everything in me, everything in my science and everything in my understanding of just how the human condition has evolved tells me that we are connected to people who are that many miles away from us in a very direct way. Their well-being benefits us and vice versa. And the idea is the idea that we share in a greater good that we all benefit from and contribute to, that we don't consciously feed and need to start feeding as a group of people in a given geography, in a given country, need to own what you, part of that work need, you need to contribute to make an adequate contribution to it to justify yourself. That discussion has to have a place to occur. We don't have a place to convene that discussion. Where can those ideas be safely put forward, acknowledged as credible, and now I'm going to accept that, incorporate it, and move forward in my next thought? That has to percolate a little bit for us to come out with a greater good definition, which is just on the tip of everybody's tongue. There is a greater good that you can define for Sacramento, California, the United States, and this region and everything else, if you so choose to define it. And you could collectively decide what that is, create a process that collectively takes everybody in this region to define it, or some version of it, shorter, maybe electronically mediated more, but almost a vote on what are the 20 things that we as a collective group in this geography feel are important to our lives as individuals, as a group, any way you want to cut it. Those discussions haven't informed what we're talking about and are a huge reservoir of information that we need to tap to understand what we need to do next. That's my basic feeling. And we need to do that in every sector we're in.
Yeah. What comes to mind for me is one of the early assertions of the late Ambassador Richard Holbrooke, who, as you know, set up the Global Business Coalition on AIDS. And in the early 2000s, he was trying to get business leaders to say what happens in the mines of South Africa is as important to the mines as it is to the auto worker in Ohio. And
that's the speech that you contributed so centrally to, started that whole idea. You never finished it.
We never finished it, that's right, because we got caught up in raising money for bloody dollars.
2000.
Maybe to add to that, though, I think there are like at least 3 really compelling arguments that we're not making to the US citizenry that we should be making if we want them to understand the value of global health. One is obviously the health security.
Yeah.
and that perhaps is the easiest of people to get their heads wrapped around. Like controlling Ebola in DRC prevents us getting Ebola in Sacramento. The second, though, I think is less well articulated, but there's a fair amount of good data that actually investing in health overseas and in health programs overseas generates income and wealth for America. And we've seen that, again, colleague and economist from Boston, Nanda Kumar, has eloquently demonstrated that I think for every dollar that is invested through PEPFAR, there is a return of about $3 back to the US taxpayer. We don't make that argument. We should do.
Yeah.
And then the third argument that I think is super compelling, perhaps requires more of a posture of humility, but it's fair to say that the US has a pretty shitty healthcare system. Unless you're wealthy, our healthcare system is overtaxed or overstretched and under-resourced. And we could learn a ton from our global health investments to inform how we scale programs more leanly, how we use task shifting, how we use data to drive programs, how we cut back on bureaucracy and fragmentation. All of those are lessons that we have learned in global health that are deeply applicable back home, and we've done a bad job of communicating those. So all of that to say that there is a story here about why global health is relevant to the guy in McDonald's in Michigan that we're not telling. We can tell because we have the data. We just need to do it better.
And it does work because we've tried that with the San Francisco Community Health Center with its relationship with our friends in AIDS Care China, but also LVCT Health in Nairobi, Kenya. How do you empower community health workers? And that's had a huge impact on the way street outreach services in the San Francisco's Tenderloin have been employed. So it's there crying out for us. Well, we've sort of come to the end of this podcast. I sense this is not an and/or, but we've not been necessarily measuring the wrong things, but we've excluded things that we should measure. We've been listening to voices that are important, but they're not the only voices. And we have been mistaking an element of efficiency for resilience. Mike, you set at the start a little task for the audience. If you've had the privilege of working with Eric, share with us that story. And, you can do that through the comments on the YouTube podcast. You can do it on all of the podcast platforms where the audio is. And just to set the scene for the next episode, we're going to take this a little bit further into the geopolitical agenda, when China, the US, and the Global South are all fighting to define the rules of global health. Whose epistemology wins? So with that, just a huge thanks to you both for giving up the time to talk about this really important book. Thanks to Eric Aspera, our director and producer, who makes the magic work. You can find us on all your favorite podcast platforms. Under A Shot in the Arm podcast, you will find dedicated places to find Redefining Global Health in the 21st century, including on our YouTube site. So it just remains for me to wish you a safe and a happy week. Thank you. Thanks, guys.
Thank you.
Thank you.